Mohan sir, Lakshmi, Mohan Rao, and all others who joined the meeting. Dr. Soumya, she'll be presenting on a case on respiratory system. And today, what we'll do is the presentation. At each step of the presentation, we'll have some discussion on that and proceed to the next step of the discussion. So this way, we don't miss any questions like which usually a candidate will be asked in the exam. So now I request Dr. Soumya to start her presentation. Thank you.
Good afternoon, everyone. Today, I'm presenting on a case presented to our hospital. His name is Pavan Hunter, and his age is 17 years. And he got admitted with us on 7th of this month, 7th of July. And he presented with complaints of loose stools with vomitings of 1 day, 8 days back to the admission, and associated decreased food intake with yellowish discoloration of 4 days and fever of 1 day with breathlessness of 2 days. And there is no past history of any significant illness in this patient, and with no history of any family history of sickle cell disease and no history of addictions or a high risk behavior. There is a history of recent exposure to a function with his friends. And on examination, he was drowsy. There was no neck stiffness, and the icterus is present with a pulse rate of 112 per minute and SBP of 90 mmHg and SpO2 40% at room air, and with a temperature of 101 degrees Fahrenheit. And his CVS is normal, S1, S2 are normal, no S3 or S4 are normals. Chest bilateral air entry is there with scattered cups in the infrascapular region, bilateral infrascapular region. And for abdomen, it was soft, there is no organomegaly. And on CNS examination, he was drowsy but obeyed commands and moving all the 4 limbs. And investigation-wise, his counts were elevated.
Dr. Soumya, can we wait here for a minute? Can you please summarize so far the history and your findings?
So this is a 17-year-old Pavan Hunter presented with a history of loose stools for 1 day, 1 week before, and with a history of fever and breathlessness of 2 days. That's all is the history, and with a history of exposure, he went to a function where he got exposed to the people, many number of people there, followed by all the symptoms started. That's all is the history, and he was drowsy. With SpO2 of low SpO2 of 40%, and with tachycardia and febrile, presented in a febrile state.
Dr. Soumya, you said SOB, and can you explain a little bit more about his breathlessness?
There is increased respiratory rate was there, and actually
breathlessness at on exertion or at rest, or what grade?
That was not there actually, but by seeing his clinical picture with the SpO2, I think he's grade 4 breathlessness.
I think you have to describe each and every symptom in detail while you are taking a history.
Okay, sir.
Okay, so 1 day of fever, what type of fever, how has it started, what is it a high grade or low grade, how many episodes, or it is a continuous? You have to take in a detailed manner. So 1 day of history doesn't suffice, and shortness of breath is a very very this thing. For 2 days it is not sufficient. And loose stools, how many episodes, what color or what consistency. There are 7 types of stools. What we are concentrating, all those we have to be telling in detail. So see, investigations and all those things are not a first thing that we have that we'll get to know, right? You have to give the detailed history, then you have to give the detailed examination findings, then only the part of investigations comes, right? Until unless with the history, you have to go what investigations you have to do, right?
Yes, sir. Um,
Okay, proceed.
Can I proceed with the investigations now?
Yeah, proceed, please.
On the day of admission, his CBC was total counts are elevated to 30,400 and the platelets of 3.4 lakhs with hemoglobin is 13.9, which is normocytic hypochromic cells. With on the peripheral smear, there were toxic granulations. Fever, dengue, leptospira, viral markers, and malaria were negative. Scrub typhus is negative, and hepatitis A is also. It was sent on the day 1, but we received it on 3rd day, and it is also negative. And his LFT is suggestive of elevated bilirubin. In total is 8.9, direct is 5.7, and SGPT is 299 with OT of 102, alphos is 409, and protein is 6.2, albumin is 3.4. INR is PT with INR is 15.9 by, and INR is 1.3. APDT is 25 by 29. And urea is 77, creat is 1.7. Electrolytes, they are 130 in sodium, 3.2 of potassium, 97 of chloride. CRP is 98, PROP is 60, and his screening test on the consecutive days it was negative. And his procal is 27.7. And his echo showed on the day 1 of admission, there's a dilated RA-RV with a mild PR and PAH with RVSP right of 38. And there's a fair LV function with EF of 52. And his HRCT chest shows bilateral upper and lower lobe consolidation with air bronchogram with soft tissue emphysema in lower 1/3 of the neck and upper 1/3 of the chest with pneumomediastinum. Ultrasound was grade 1 fatty liver. CTPA done, it is negative for thromboembolism. And which in the ending, I kept the slides I'll be showing. It was of day 1, there was a respiratory alkalosis. And these were the X-rays. These were the consecutive X-rays he presented. I could able to get 4 X-rays only. And this is the X-ray on the day of admission. And consecutively also this. And this is like some 14th of the, he got admitted on 7th. And 14th X-ray it is. And another X-ray is
Dr. Soumya, we go from day 1. We go from day 1 and from your investigations, we'll discuss about our findings and see where it fits. Okay?
Yeah.
So don't go to 14th from day 1.
Yes.
Okay.
And this is the ECG. There is no evidence of any infarcts except for the mild LVH. And this is the CT scan on the day 1 he presented. On 8th of 7th, he got admitted in the night, and this is on 8th. And this is the HRCT with the
Can we go back to your investigations on day 1?
Yeah.
Day 1 investigations.
Yeah.
Yeah. Please, from your findings, from your lab investigations, what can we make out?
This patient is having toxic granulations with elevated total counts and with elevated liver enzymes with elevated bilirubin, that to direct bilirubin, and elevated CRP, procalcitonin, and TROP-T, with deranged creatinine and urea, and with a mild elevation of INR 1.3.
Soumya,
Ma'am.
hello.
Yeah, ma'am.
Soumya, you got a total count of 30,000
30,400.
plus, right? And
Yes.
what is your differential count?
Ma'am, I'll tell you. I didn't keep it in here.
I want to know about the differential count,
Yeah, ma'am.
and if there is any RDW, you can make a note of it.
Yes, ma'am.
And on your peripheral smear, have you got any band forms?
Peripheral smear, they have written only toxic granulations, madam, from the lab. But a differential count, I didn't mention in this. I will tell now. Differential count is 85% of neutrophils and lymphocytes of 8 ma'am, eosinophils 2, and basophils of 0.
Okay, you got the differential count, more neutrophilic leukocytosis, right?
Yes,
And
ma'am.
you got elevated CRP.
Yes.
Yeah. And you got toxic granules in your peripheral smear, right? Do you think you need to do PCT for this case?
Excuse me.
Or what's the
Procalcitonin.
use of PCT at this level and significance of a PCT?
Procalcitonin, ma'am.
Yeah.
Procalcitonin is 27.7. It's suggestive of bacterial infection, ma'am.
No, when you have cell counts of 30,000 plus and
Yeah.
neutrophilic leukocytosis, your CRP is already elevated. You have toxic granules. So is there any doubt about that? It could be bacterial infection. Do we need to do PCT at this level? Do we need? When we see
no
picture
need,
like
madam.
this?
No need, madam, but for the future prognostication, it will help us, ma'am.
What do you mean by future problem?
In the coming days, the treatment de-escalation time and all, it helps us.
Video audio musunaru.
Excuse me. On the day, it is not no need to be done actually, but while we are de-escalating the medication, it helps us.
Go ahead, what happened? Any more questions? Go ahead, Amma.
Hello?
Yeah, ma'am.
Continue.
Yeah, sorry, I think I was on mute. I said PCT when it's not clear-cut picture about bacterial infection on your cell counts or smear, or when you think it could be viral, so or for de-escalation purpose, you can do PCT, but
Yeah.
not as a routine when it is a clear-cut picture of a bacterial infection,
Yes, ma'am.
right? So, okay. And you got troponins as well. Troponins.
Yeah, ma'am. Because he was having breathlessness and in the lung there are infiltrates. To know the cardiac any cardiac issue, I think they have done the TROP-T, ma'am.
Okay, tell me DDs of this picture. Fever, breathlessness.
One is pneumonia.
Okay.
And one is pneumonia, ma'am. Infection in the lungs, pneumonia.
You have done so many investigations, so probably on your mind you have so many conditions could be present. So you have done all these investigations. So
And
tell some DDs, right?
excuse me, ma'am. He was breathless for 2 days, ma'am.
Hello, Soumya?
Ma'am.
Yeah, couldn't hear. You were saying about the DDs, pneumonias, what all pneumonias can be present and what are the what are the other conditions which can cause
The
fever,
other conditions,
dyspnea.
because he was having loose stools and vomitings, that can be a simple, started with acute gastroenteritis, and there can be like viral hepatitis can be preceded by the loose stools. So that's why the LFT was being sent, and other fevers like dengue, leptospira also can present like this, followed by they can have the viral pneumonia in dengue, and leptospira can also have present with loose stools, and then followed by increased liver enzymes and bilirubin in leptospirosis, and viral pneumonias, even though hepatitis virus can have the gastroenteritis followed by jaundice, and malaria also can present with fever, loose stools, abdominal pain like that. So they have done the malaria. Hepatitis is done, and scrub typhus is also can present with fever. And if it's been treated late, they can develop pneumonia also in scrub typhus.
Leptospira,
Yeah.
how did you check?
Leptospira IgM in the blood we are checking now.
Okay, fine. We have done sickle test as well, right?
He hailed from Orissa, and his LFT was elevated. He was having jaundice clinically. So in view of that, sickling test was being sent.
Okay. Did you see any sickle cells in peripheral smear? Any fragments or sickle cells?
Yeah, we get sometimes we can see, ma'am, but they do sickling. I don't know the procedure, how they do it. I'll read out it.
No, I'm saying if there is any fragmented cells or sickle cell, you would see on peripheral smear to suspect it could be a sickle cell disease.
Yes, ma'am.
That's what I'm saying. So in this peripheral smear, I don't think we have seen any such cells, right?
Only toxic granulations were given in the peripheral.
So when we do some tests, like we have to have the probability at least, or strongly suspected by the clinical picture. Otherwise, just simply doing lot of
చెప్పండి
tests.
హ్యాండింగ్ ఓవర్ ఇచ్చేద్దాం వరుసగా చూసుకుంటాను కదా ఇక్కడ
So actually, we didn't need to do sickle test here. Okay, troponins, you said SOB, but SOB is a vague thing. Just any ECG changes?
ECG wise, no changes, ma'am. Actually, there is borderline LVH was there. If we add in V2 and V5, that's all. It's a sinus rhythm, and that's all. ma'am.
Okay. So PCT cost, troponin cost, they are not very simple tests to do. Sickle test, all these are quite expensive tests.
Yeah.
So when we have a clear-cut picture of something, I think we could have waited for a bit longer to see if they are really needed to do, right?
Okay. ma'am.
In exam, examiners ask, whatever you do, why did you do? Why did you do? And justify. So we have to show some justification there, right?
Yes, ma'am.
Okay. Okay, proceed. And what is your, like, you just done hepatitis A thinking that, I mean, actually the patient presented with jaundice
Yes.
on presentation. So when hemodynamics were reasonably stable.
No, his SpO2 was 40 and BP was 90, ma'am. SBP
Okay.
was 90. Diastole was not recordable, I think.
And your tropical fevers all negative.
Yes, ma'am.
Okay. So what could be the cause of jaundice by your LFTs?
Like if the reports were not there, I would like to think in malaria, it can cause jaundice. And in hepatitis, there will be a jaundice. And if the severe sepsis is, in severe sepsis also, there can be a multi-organ dysfunction with sepsis-related jaundice can be there. If it is leptospiro, there can be jaundice.
Yeah, all those are negative.
Yes. So
But you said
jaundice,
sepsis
because
can be,
ma'am?
sepsis can be, all the tropical fevers are negative, right?
Yes, sepsis-related jaundice, this is I'm thinking.
Yeah, what could have caused this sepsis, causing the jaundice?
Means how sepsis is causing jaundice, you are asking, no?
Yeah, in sepsis, what all the causes which can give this LFT picture?
Hmm.
Have you done ultrasound abdomen?
Yes, ma'am. There is grade 1 fatty liver is there.
Any cholangitis signs? Any
No, ma'am.
cholecystitis?
Only grade 1 fatty liver is there. There is no other vision. If it is cholangitis, they can have direct hyperbilirubinemia with alpha elevation. But ultrasound doesn't show any gallbladder thickness or any stones in the gallbladder. Only fatty liver is written. Ma'am?
Okay. Yeah, and you have done only hepatitis A, right?
B, no ma'am, all viral markers done. Hepatitis B, C, and HIV were negative.
E,
Hepatitis B,
E,
it's PSAG.
hepatitis E,
E wasn't sent, ma'am.
A and E
E-
by
A
food
sent, but E was
contamination.
not sent.
Yeah.
E
Yeah,
also
more
supposed
than
to be sent
more
back.
than C could have done hepatitis E.
Yes, ma'am.
Okay.
E was
And
not sent.
And is there any possibility of acalculous cholecystitis?
Yeah, there can be a calculus cholecystitis also, but if we leave the ultrasound here, but patients can present with a calculus cholecystitis, where the bilirubin levels and they'll be elevated OTPT, but alphas will be more elevated. That can be also there.
What is your alkaline phosphatase?
Here it is 400, mild elevation is there, 409. All were elevated 2 to 3 times.
Right. So after your presenting illness history and investigations, what is your provisional diagnosis and what are your findings? What are the system findings?
Yeah. The findings clinically, he was having fever and BP is low. He was having fever, breathlessness is there with jaundice. And BP is low, less than 90, with the diastole not recordable, and SpO2 to 40%. And with investigation suggestive of elevated total counts, neutrophilic predominance with toxic granules, and LFT with elevated OTPT and alphos with bilirubin elevation, with mild derangement of the INR, and mild derangement of renal function also. CRP, TROP-T, and PCT were all elevated, and the chest X-ray is showing bilateral infiltrates, as well as his CT was showing upper and lower lobe involvement of infiltrates and bilaterally. So my diagnosis is this patient is having community acquired pneumonia with sepsis, with multi-organ dysfunction involving the blood pressure, involving the counts, and with the transaminitis, and mild renal dysfunction. So sepsis with MODS and community acquired pneumonia like this.
Okay. What is okay, coming to community acquired pneumonia, what are the scores, do you know?
Madam?
What is the definition of community acquired pneumonia and what is severe CAP?
Okay.
What is CAP? What is severe CAP?
Severe CAP, we define by the indices, madam. Pneumonia is presented with cough, sputum, with any chest pain and chest pain, that's a pleuritic pain like with dyspnea, they present. And severe CAP, according to the pneumonia severity index, It is severe people having severe 65 and
Hello?
ma'am.
Yeah. Say it again, couldn't hear. Yeah, you said about the cap.
Clinical history is like cough with expectoration, with plus or minus breathlessness and chest pain, which can be pleuritic chest pain. Usually they present like that, pneumonia. And severe cap is severe
No,
communication.
in cap you haven't completed.
Ma'am.
Fever, you missed the fever.
Cough,
Fever, cough,
fever,
breathlessness,
cough,
productive
breathlessness,
sputum.
productive sputum. And generally they can present with confusion, upturned,
X-ray findings.
and chest X-ray findings with infiltrates bilateral.
Okay, that's a cap. Severe cap is
Severe cap by pneumonia severity index or curve 65. And smart pop, those all we will be identifying the severe cap, madam.
what is severe cap is severe pneumonia which requires ICU admission for organ support.
Okay.
That's-
Yeah,
Okay.
severe pneumonia is like requiring ICU admission with vasopressor support and intensive ventilation. Yes, ma'am.
Okay, continue, please.
And these were his serial X-rays from the day 1 to the day on just before he died, 1 day before it is. And these are the CT findings, which shows bilateral upper lobe and lower lobe infiltrates. And this is a CTPA. It is negative for thromboembolism. And the treatment he was started on 8th of July. Started an injection NORAD infusion as his BP was low. And antibiotics, Piptas was being Piptas 1 gram IV 8th hourly started, 4.5 gram IV 8th hourly, and Targocid 400 mg IV BD for 3 doses, followed by 400 mg OD once in a 48 hours being started. IV fluids at the rate of 50 ml per hour is started. As his potassium was low 3.2, so they added KCL. We added KCL and injection Pantocid, and he was on O2 with NRB mask, with which his SpO2 was maintaining at 94%, and for fever PCM. And at the time of admission, because the scrub and all the reports were not ready, he was also being started in doxycycline. And nebulizations, dual nebulization was started on the day 1.
What was the respiratory rate on admission?
Actually, that was not mentioned in the case sheet, madam.
Yeah, you said saturation 40% on room air.
Yes, ma'am.
So I just wonder what could be the respiratory rate. And you started on oxygen by non-rebreathing mask. So at that level, that's one question. And patient has patient has AKI, right?
Yeah, ma'am.
What kind of AKI you call it?
This can be pre-renal.
So
Because his
pre-renal
BP was also
AKI.
low. BP was low.
Yeah, pre-renal AKI, BP was low.
Yeah, ma'am.
So what would be your first, like, you started NORID. So what would you have
We
done?
should start him on IV fluids. 30 to 35 ml per kg IV fluids to be started.
30 to 35 ml, is it?
Kg. His respiratory rate was 40, madam.
So his respiratory rate
At
was
the time of
40,
in the IC,
saturation
not
was-
in the ICU, ma'am, in the casualty, his respiratory rate was 40. Yeah. Temperature
Okay.
was 101.
So you think NRB mask oxygen is good enough?
Madam, hello, can I talk?
Yes.
Yeah, please.
Madam, first thing is the diagnosis. When you asked differential diagnosis, you told pneumonia. First thing, what is the differential diagnosis of breathlessness? She has to give all different types of respiratory, cardiac, all these issues, and sepsis, and various other organisms involved in sepsis, all these things. Second thing, when it comes to treatment, a treatment protocol should be in a proper order. Like first what she will do, first what so like surviving sepsis guidelines, sepsis and septic shock. What is the first preference in case of whatever pneumonia or whatever? Should be come in a order. So this order is, I think, it is not properly.
Soumya, what
ma'am,
should
here.
we do? What should we do if you have such case in your ER or straight away come to your ICU? What do you do? Saturation 40%, respiratory rate 40, temperature. No, you didn't even get any investigations, but you got the vitals. You got BP 90 or less.
Yeah. If clinically, if I don't get any any murmurs or any S3 or S4 gallop like that, I would like to, this patient, I would like to give IV fluids one side, and for oxygen, I would start him on a mask ventilation. And
Respiratory rate of 40 and the saturation, rate 40 and saturation also you gave 40. So do you think just mask oxygen is enough?
he will need more oxygenation, madam, actually. NIV, I can start him on NIV.
Okay. And about resuscitation?
And
Go in sepsis protocol. You have given a picture of
Why there is
sepsis and shock.
contraindication? Why you did not take a intubate? Why don't you intubate patient? What is the contraindication? Why you think about intubation? First of all, the patient is in shock and hypoxemia. ABC should maintain always airway breathing circulation.
We can ventilate the patient, sir, but
Yeah, simultaneously start with the fluids and give a intubate the patient about the 40 saturation is always. Is it a patient? What is the sensorium? 40 sensorium, is it patient is unconscious?
drowsy, sir. But he is
40, I
obeying
don't
all
think
the
any 40 patient won't be drowsy. He will be almost porous. You cannot put a NIV also. You cannot put a NIV also.
And he improved with the NRBM mask. That's what written here.
Yeah, I think you are not treated the patients. I mean, the ICU, in the ER, maybe they done it. Is
Yeah.
only, but what actually when you present, what you do? Are you put a NRBM mask or you directly intubate the patient?
I will directly intubate the patient if it is 40%. Patient
no.
was drowsy. To secure the airway, I will intubate the patients.
If the patient is conscious, till you talk to family, get the consent, probably you can put NIV, go straight to NIV, 100% oxygen. Then meanwhile, you do the fluid resuscitation and talk to relatives, take
Yes.
consent and do it. But straight away, go for some modality of oxygenation. Just when he's drowsy and you don't know how his breathing rates are 40 plus, then just NRB mask is not sufficient, right?
Yes, ma'am.
Okay, then about coming to sepsis guidelines. So you said this patient is in shock,
Yes.
confused. And do you want to say about the curb 65?
Sub 65,
You-
confusion, urea of more than 20, respiratory rate more than, he's not 65, but 4 of curb is 4 points are coming now.
Okay, yeah. Right. Yeah, carry on. Continue. Yeah, what are the other scores?
Excuse me, ma'am.
What are the other scores?
Of the community acquired pneumonia. One is curb 65 and PSI index is pneumonia severity index and smart cop. And then ISPAN associates, they do have a score for major and minor criteria. ATS IDSA guidelines. They take consideration with PSI and ISPAN associates, and they formed guidelines for this.
What are the major and minor criteria?
Of ISPAN, ma'am?
Yeah.
Major criteria is one is BP and pH, ma'am. pH of less than 7.3 and BP of less than 90. They are the major criteria. And minor criteria, confusion, urea of more than 30 and respiratory rate of more than 30. Chest X-ray rise infiltrates in both lungs. Then age more than 80, and another 2 are PYF ratio less than 200. These are the 6 minor criteria. Any of one major criteria or 2 minor criteria, then this is called a severe captain.
So are you fitting in that?
Excuse me, ma'am.
Are you fitting in that criteria?
Yeah, he's fitting in that criteria.
Okay.
SPP is low. One major criteria already did fit. So, and
Okay.
bilateral
Okay.
pulmonary.
Continue with your management. You said sepsis and doing fluid resuscitation. What do you do? Fluid resuscitation, then how do you resuscitate? What else?
Because his BP is low, 30 to 35 ml per kg, I can give the fluids. Bolus, I can give a bolus of 500 ml to 1 liter. And continue the IV fluids, 30 to 35 ml per kg. Then and start him on IV antibiotics because I'm suspecting
No,
community.
you have given about 1500 ml of fluid.
Yeah.
You are worried because on presentation itself, you said you heard basal Krebs.
Yes, yeah, ma'am. But
So your
his
BP is
cardiac,
not increased.
okay. So I will be starting him on noradrenaline
How
infusion.
if you want to give some more fluid, what do you want to check? Whether you can give more fluid or not, or simultaneously give fluid and start NORAD, what do you want to do?
CVP, central venous pressure.
CVP?
Or,
Are you doing CVP
no,
on your
no, they are
patient?
not doing. Um,
Through echo, what we are doing, looking, Soumya?
we
Without
do
getting fluid.
echo and ultrasound also we are doing, sir. Echo, I can see whether this patient is having any LV dysfunction by checking his ear. If EF is normal, I can.
Fair LV function. Fair LV function.
Their LV function is having
What do you want to check?
diastolic dysfunction also.
Not there. He's young fellow, 17-year-old. Maybe mild diastolic dysfunction. You said RA-RV dilatation and mild PAH.
Yeah. RESP, RESP is 38.
Yeah, you said that. That's why I'm saying. What else you want to look at? Whether to continue with your fluid resuscitation or start anything else if your BP is not picking up.
Actually, I didn't read this. I think we'll look at TAPSI, ma'am. LVOT gradient. LVOT,
Do you do?
I'm not doing it.
What else can you check? Patient is not putting out much urine. You know, his oliguric, probably AKI, probably pre-renal. Can you check your IVC? Can you check for B lines?
I can check for IVC. In ultrasound, I can check for B lines to know whether there is any fluid overload state in the lungs. If it is not there, I can give more fluids.
And
B lines are not there, and IVC collapse is there, then I can give more IV fluids.
no, IVC is kind of reasonably filled. You have RA, RV
RESP is
also
there.
dilated. Your BP is not picked up. Already you have pneumonia, so it's not very clear. How do you differentiate B lines pneumonia?
Pneumonia, they'll have a shred sign or dynamic air bronchogram on B scan. And B. And
Okay. Right. What do you want to do to get your BP up?
we can start in a NORAD, ma'am, or anything else.
Okay, you tell me. Yeah, you started NORAD.
Yeah.
And
At
this stage, patient relatives were counseled and they accepted to go for intubation,
Yes.
right?
Uh,
And what about in sepsis management? What else you want to do? in first hour, first 3 hours.
Yes, ma'am. I didn't prepare on this actually. Sepsis, ma'am.
See, your diagnosis itself is severe CAP sepsis. So,
Yeah, ma'am.
sepsis management, sepsis guidelines, whatever the cause is, guidelines are same, right?
Yes, ma'am.
He has fever, he has cough, hypotension, desaturation, and you are about to intubate. And you have given fluids, you have started NORAD,
Yes, ma'am.
you got airway controlling. So what's the next one?
Antibiotic.
What's the ABG? You have done ABG, right?
On the day 1 of admission, 7th, I didn't get the ABG, madam, but on 8th, the ABG is this month.
No, on 7th, on admission day, when patient so sick
Lost
and
the
so
ABG,
bad.
madam. But I got on 8th at early hours of 8th. Yeah.
Okay, I'll tell an ABG. pH 7.3.
7.5.
7.3, I'm saying. PCO2,
Ma'am, what is 7.3?
PCO2, 40. PO2, 35.
Okay.
Lactate, 5.
Yeah.
Basics is -8.
Okay, ma'am.
And your bicarb,
Yeah.
18.
Excuse me?
18.5.
18. Yeah.
So this is your ABG. And you're planning to intubate this patient, right? Hello, Soumya, continue with your management.
This is you gave me this ABG, madam.
Yeah, it's like that. So you have a sepsis patient.
Yes.
What do you want to do here? Resuscitation part, intubation part over. Then what next? I gave you lactate also. I've given you the picture. So you plan to intubate him. What next?
Lactate is more and PO2 is very low, 35 only. SPO2, madam?
You only said
Yeah,
it's 40%.
Yeah, madam.
On the monitor.
Yeah. This patient is having metabolic acidosis with high lactate, suggestive of hypoxia. Lactate is elevated because of the hypoxia.
Because of?
Because his ongoing hypoxia and sepsis, his lactates are elevated.
It's not because of hypoxia. What do we say? Why lactate is increased? What's your blood pressure?
Blood pressure is also very low, ma. So less oxygenation is causing cellular injury and lactates are elevated.
Hypoperfusion.
Hypoperfusion, yes, hypoperfusion. And
Okay, continue with your management work. You have done up to fluid resuscitation. You have started NORAD. You are planning to intubate.
Yes.
Got the consent. And so how do you go about intubation? You got, is it NIV on or you got NRBM? So you
because
have
we got
NIV.
into the
Okay,
ICU. Yeah. I start,
take it, you have NIV.
yeah. By the time
Patient is drowsy but irritable.
I would go with intubation, but till I get the relations consent.
You got the consent. You got the consent.
Then I would like to.
How do you go about intubation? Your blood pressure is between 90 and 100 systolic.
Yes.
And you have 100% FiO2 of 1 with NIV.
Okay.
Tell me about the intubation. What do you want to give? How do you intubate? And what do you want to set up on your ventilator?
Intubation, I'll give sedation followed by
Be
paralytic
specific,
agent.
Soumya. Be
Yeah, ma'am.
specific. What do you want to give? Just don't just say the group of drug, but just say specifically which drug and how much and which one you want to avoid.
I want to avoid propofol like drugs because it will cause hypertension. So
Okay.
I can give 0.2 mg per kg, 0.2 mg per kg loading dose.
Which one?
Fentanyl or
Okay.
along with that, I would like to give
Sorry,
a paralytic.
0.2 mg. Did you say 0.2 mg per kg?
Yeah, and 0.2 mcg per kg. ma'am.
So how much will it come for a 70 kilo young guy?
Hmm. 0.2 mg. ma'am. 0.2 mg per kg.
0.2 mg per kg. 0.2 mg means
Propofol.
is it 140
Fentanyl
mics
is available
kg?
in 5,500 mics. Yeah, ma'am. 0.2 mcg per kg. will be. 70 means it's
Not 0.2. Maybe you can say 2 mics per kg.
2 mics per kg. And followed by, I will give a paralytic agent. Acronym or acronym.
Do you want to give paralytic agent just with fentanyl?
In a rapid sequence intubation, we will give a sedation followed by a paralytic agent. Then we will intubate the case. Ma'am. Rani, ma'am.
Hello.
Ma'am,
Sorry, my line got disconnected. Say it again. Yeah, you got fentanyl.
usually we do give a sedation followed by paralytic
What
agent and
sedation?
then
What sedation you want to give?
pentamidas we can give. Midas like 3 mg, 2 to 3 mg. Midas followed by fentanyl. And then give a paralytic agent and intubate the patient.
So what paralytic agent you want to give?
Becronium or rocronium we can give them. I don't remember the doses.
Well, doses, it's
Read off
okay.
those.
Did you plan? Did you say you want to do rapid sequence?
Yeah.
Yeah, for rapid sequence, which one would you use?
Succinylcholine can be given. If there is no family history of
Okay. And the other one?
becronium and rocronium can be given.
How long does it take to work for vecuronium?
It takes 2 to 3 minutes now, 1 to 2 minutes.
In rapid sequence induction, do you think you can give that? You're not anesthesia background, are you?
No, ma'am, I'm not.
So in rapid sequence, you don't ventilate after you give the relaxant. You just pre-oxygenate and you wait till you intubate. So can you wait for 2 to 3 minutes without ventilating?
No, even though it is tricky, we'll be oxygenating the patient with ambu bar.
Sorry?
We'll be with ambu, we'll be keeping the mask. We'll be oxygenating the patient till the patient gets paralyzed for that 1 2 minutes. And
So with ambu, if you put just the ambu mask on, do you think it will oxygenate?
no, we fix it on his face with oxygen. We'll be oxygenating them and re-oxygenating the patient.
No, I'm asking, unless you bag the ambu bag, will you oxygenate the patient? So
And
just by applying ambu mask,
no,
do you
not
think?
the ambu applying, just keeping on the face with and fixing with our hand on the face, attaching the ambu with the oxygen, high flow oxygen, and we'll be bagging the patient.
That's what I'm saying. When you're doing the rapid sequence intubation, you're not supposed to bag.
Oh.
So when you think patient is full stomach, when you're planning to do rapid sequence, if you bag, you'll be insufflating the stomach more and you'll be causing more aspiration, more risk of vomiting and aspiration.
Okay, ma'am.
In rapid sequence, you apply cricoid pressure. So to prevent aspiration, but still you'll be distending the stomach more.
Oh.
So you should not. So vecuronium is not the choice. As you said, either succinylcholine or rocuronium, which is the quick acting ones. Okay, carry on. And when you have NIV with 100% oxygen, you oxygenate, and if you do the rapid sequence, you take it out. But if you're not doing the rapid sequence induction and intubation, you can continue with NIV with 100% oxygen or put the nasal cannula
Hmm.
and AMBU. If you're not doing the rapid sequence, you can put nasal cannula, and you can also on top, you can use the AMBU and do the intubation if you're not doing rapid sequence. And the other thing is, if you have high flow oxygen, if the patient is already on high flow nasal oxygen, you can continue with oxygenating with that with 100% oxygen while you intubate. So these are the options depending on your patient condition, depending on what kind of intubation you're doing, right?
Okay.
Okay, you have intubated, but it's already 45 minutes over since your patient has come to you.
Yeah, ma'am.
And in your sepsis bundle, you haven't done few things yet.
Yes.
And you thought it's a cap causing, severe cap causing sepsis, septic shock.
Hmm.
What do you want to do now?
So I have given the IV fluids, now, right? Intubated the patient. Antibiotics, and I will connect him to the ventilator with the
Okay. Tell me the ventilator settings. What do you want to do?
and low tidal volume. And keep low tidal volume, I would like to keep around 6 ml per predicted body weight. And
What are the settings? What are the parameters you set on your ventilator?
one is FiO2, I'll be setting the FiO2 one, and PEEP and low tidal volume. Tidal volume, and I keep it in a AC, ACDC mode. Assist control mode.
You didn't tell me about FiO2, your PEEP,
Yeah,
your trigger.
PEEP, minimal PEEP of 5 to 6 I'll be keeping. And low tidal volume at 6 mg per kg predicted body weight I'll be keeping. And FiO2 in the starting, because I'll start with 100%, then I'll gradually come down, depending on the patient's oxygen saturations. And I'll keep up to 0.6 to 0.4, I'll come down.
Or you have bilateral opacities. You have very low PO2 levels, very low saturations, and you got FiO2, high FiO2. So what would you like to set your PEEP on?
Last
PEEP.
time.
Do you think PEEP of 5 or 6 enough for this patient?
No, up to 10, I can keep up to 10 in this patient, madam. Like when I'm keeping at 0.6, 10 to 12 PEEP I can keep for this patient, madam.
Okay, you've set the settings. What do you want to do next? You set volume control. In volume control, what else do you want to set? FiO2, PEEP, cardio volume, and 2 more.
And frequency of the respiratory rate.
Yeah.
Will be setting. Tidal volume, frequency of the respiratory rate, and P and FiO2.
You got assist control, right? So
Yes.
do you want to set trigger?
Yeah. I will set the trigger also. Trigger volume pressure. Yes, ma'am.
Sorry,
Trigger also I need to set it.
what trigger?
Trigger is yeah, trigger I should set that I don't know.
I'm not asking what is trigger. What kind of trigger you set? What are the types of trigger and what would you prefer to? What would you choose to set?
Um,
Okay. Flow trigger or pressure trigger, right?
yeah, two triggers will be there. Yeah, ma'am. Low trigger, yes.
Okay. You set the trigger also. You set the ventilator. That part you started. Okay. Then what next? See, I'm not going in depth of any
Yeah,
of these.
understood, ma'am.
I'm asking just the basics
Yeah.
to see if the candidate is like safe. That's all they check in exam. Safe and don't do blunders.
Yeah, ma'am.
That's all they want to know. So you've done the ventilator, you intubated, you started connected to ventilator, you put the settings. So you've taken care of A, you're doing B, you've taken care of B, and you're doing C also. Then what next?
Antibiotics.
Yeah.
Antibiotics to be started, madam. And
Mhm.
because it's a community acquired pneumonia, I will look for community acquired pneumonia. I'll be covering the I'll start with the beta lactams. Because they
Soumya, before you give the antibiotic, would you like to do anything? For example, you didn't know this could be CAP, this could be anything because patient has so many other complaints also.
yeah,
But you know this patient is in septic shock.
yes. I would like to send the cultures, madam, blood culture, and if possible, I can send for the sputum culture also, with sputum grams too, so that I can know what
Sputum, why sputum? Why sputum? You have already intubated.
I can take ET secretions also.
Okay. So you want to send blood and
Yeah, blood and ET secretion culture. And I'll start the patient on antibiotics, covering both the atypical and strep pneumonia, mycoplasma, with beta lactam with macrolides. Or if the patient is no, beta lactam is not a resistance, beta lactam allergy is there, means I can go with the quinolones. which can cover both atypical and bacteria.
Do you want to go for a combination therapy or do you want to go for a simple therapy?
I would like to, because this patient is having severe CAP, I would like to go with the combination therapy on this.
What combination you wanted to go for?
Selected with beta-lactams like piperacillin and tazobactam. With the
Piperacillin tazobactam is beta-lactam or something else?
extended beta-lactam. Yes, extended beta-lactam it is.
No,
Beta-lactam.
is it a combination? Is it a combination or a single antibiotic?
Piperacillin with tazobactam, sir, it is.
Yeah, is it a combination of something or simple beta-lactam?
It is a combination of extended beta-lactam with
What is that?
it's a penicillin, sir.
I
It's a
understand. It is a
BLI kada Soumya.
Madam?
It's a BLI, no?
Yeah, beta-lactam, extended beta-lactam they call it, madam.
No, what madam is saying is right. So it is a combination of beta-lactam with beta-lactam antibiotic. Beta-lactam inhibitor.
Beta-lactam inhibitor. Yes, sir.
ESBL is the coverage.
Yeah.
Okay.
Yes, sir. Piperacillin is an extended spectrum penicillin lesson. With tazobactam is a beta-lactam. What you are telling, sir?
Okay. You want to go for combination, means you want to go for any other class of antibiotic or just wanted to continue with piperacillin
And
tazobactam?
I would like to go with macrolide also, sir. Either azithromycin or clarithromycin. I would like to add on.
Okay, why you have to use a beta-lactamase inhibitor first thing, and why you have to use a macrolide?
Macrolide is to cover the atypical organisms, sir, like
No, what is atypical pneumonia?
sir.
What is atypical pneumonia?
It's a viral pneumonia, sir. Actually, viral pneumonias claim.
Atypical is because of the organism or because of the presentation?
Because of the organisms. Sir, because of the organism.
Presentation.
Okay, Soumya.
Ma'am.
Okay, continue with your presentation. So you started with piptas and macrolide.
Yeah.
Okay. Yeah, macrolide to cover atypical organism, right?
Yeah.
So do you think macrolides or fluoroquinolones, which are the better to use as combination with your beta-lactams?
Here,
In CAP.
the severe CAP, I can go with the quinolones.
Do you not think macrolides are preferred? You only said
Yeah, usually,
atypical cover.
yeah. Quinolones, they do cover atypical also.
Do you have any studies for comparison or any guidelines which suggest which one is preferred?
ATS IDSA guidelines is there.
Which suggests macrolides, I think,
Ma'am?
referred to. Which suggests macrolides referred to quinolones. Okay, continue. Continue, Soumya.
This patient was started on antibiotics Piptas with doxycycline, madam, and also started on nebulizers. And on the day of admission in the ICU on 8th, by evening, he was on NI. As I said before, he was on NRBM mask. In the evening, he was being shifted on to NIV. And on 9th, with NIV, his FiO2 was on NIV with FiO2 of 80. He had it was increased to 100% FiO2, and his respiratory rate from 48 it went to 56. And his ABG was showing 7.4 pH, PCO2 51, and bicarb is 33, with suggestive of compensatory respiratory stenosis.
Soumya, just skip this slide and just imagine you have already intubated and ventilating.
Yes,
but still the patient is not improving. And you have started antibiotics, right?
Yes, ma'am.
And your NORAD is going on.
Yeah.
You are on invasive ventilation. Okay? With?
Yes.
Yeah. And now tell me about the condition of patient and continue with the case. Skip the part of intubation because we have already intubated.
Yeah. Actually, his peak pressures were raising to 65 and plateau pressures were 55 with a FiO2 of 90 and P by F ratio was 50, ma'am. So in the evening, they did proning to him.
No, when his pressures are so high, what's happening? Is the patient sedated with what?
Yeah, the patient was sedated with fentanyl infusion and cisatrapyram at 1 to 2 microgram per kg per minute. Now.
Only fentanyl?
Yeah,
And
cisatrapyram? He was sedated with only fentanyl. And I think it was not mentioned. Midas also would have been started, madam. Pentamidas.
Okay. And did you say cisatracurium infusion going?
Yes, ma'am.
Is it because, is it after worsening or before worsening?
If this is after intubation, doesn't mention.
Okay, because rates are high. In spite of sedation.
In the before slide also, yeah. He was intubated and kept on FiO2 of 90, PEEP of 14, and tidal volume was 300 that time, man. And they start him on fentanyl. Usually, in our hospital, we start with fentamidazole.
Okay, PEEP of what? Sorry, did you?
PEEP is 14 they kept, man.
PEEP 14?
Yes.
Okay. You sedated and you plan to prone, is it?
Yeah. They proned him in the evening, madam. First proning. Because his plateau pressures were 65, 55.
What are the indications for proning?
Yeah. High plateau pressures more than 30, ma'am. Severe P by F ratio less than 150 and and
ప్రోన్ పొజిషన్ ఇండికేషన్ తెలియకుండా ప్రోన్ పెట్టావు సౌమ్య.
What can you do to reduce your plateau pressure? You set your tidal volume 6 ml per kg, right?
yes, ma'am.
What all can you try to reduce your plateau pressure?
I can decrease the tidal volume. If the plateau pressure is more than 30, I can decrease the tidal volume for 1 ml per kg. And see whether
Up to?
I kept it 6. I can decrease 1 ml per kg up to 4 to 5 ml per kg. I can decrease.
Okay. Then? Is your patient still agitated on ventilator?
Patient is already on fentanyl with cisatracurin.
To start with, you didn't start cisatracurium. If already patient on cisatracurium, when your set rate is 20, how can he breathe 40 to 50 per minute?
I can increase set rate. I can increase his respiratory rate, madam, to up to 35 actually.
No, I'm saying you have paralyzed the patient. So when your set rate is in 20s, how can it go to 40, 50s? And when your plateau pressure is so high, when your rates are so high, even with like you are saying you already started cisatracurium, what's happening here and what do you want to do before you go on to prone?
Rashmirani, don't do too much of time, eh? Just immediately should say answer or should you ask a next question? Time is already over.
తెలియకపోతే తెలియదని చెప్పండి.
Fast. No, don't waste time. A lot of time is wasted.
I don't
Just even the moderator also wait for a few seconds. If you're not done, you say answer or go ahead next question. Because it's already 2 hours, almost quarter to 2 hours.
Soumya,
I don't
you check your sedation levels. Maybe it's too low sedation. You increase the sedation. You titrate your neuromuscular blocker. Unless you go on to prone, if you're supine, you don't have to, as a routine, use neuromuscular blocker. Okay. If there's a lot of asynchrony and not ventilating well, in spite of all other things, then only go for neuromuscular blocker. But otherwise, no need of a regular routine infusion of neuromuscular blocker. Okay, unless it's bad ARDS, as you said, you're proning, all that. Okay, so here you check all your sedation, your paralyzing agent, your settings. You go down a little bit on your tidal volume. Lowest is the 4 ml per kg. Okay,
Yeah.
right. So, okay, you are prone now.
And his antibiotics were escalated from piptas to meropenem. Because within he was within few hours he was prone, thinking piptas may not be helpful, changed to meropenem. And on the day 3,
Soumya, what are the contraindications for proning a patient?
for proning, ma'am.
Yeah. When you decide to prone somebody, you have to check if there are no contraindications to prone this patient.
Yeah, ma'am. I don't remember, ma'am, contraindications.
What is your now? What is the how much of vasopressors are going on, madam?
Vasopressor, it was going on changing, sir, like 10 ml, 15 ml, like that.
The
So,
contraindication
it was
higher,
not mentioned there.
higher dose of vasopressors contraindication?
Yes, sir. It is one of the contraindication for proning.
So your hemodynamic instability is contraindication.
Yeah, ma'am.
Yeah.
Yeah.
And if you have any, not in this case, but in general, if you have any facial injuries or raised ICP conditions, all those contraindications.
Pregnancy,
Yeah.
pregnancy.
Pregnancy is a relative contraindication.
Yeah.
Okay,
Any
Soumya.
face injuries. And on,
Continue, please.
and on 10th, patient was still febrile, and his PCO ABG is like 7.3 was the 7.34 is a pH, and the PCO2 is 71, and PO2 is 124 with bicarb of 43 with FiO2 of 80%. His P by F ratio was 155, and day before at the evening he was being prone, and the evening again they supined him, and he was still on NORAD and vasopress infusion. At this point of time, the ET culture was sent. ET culture and blood culture was sent. On that day, from 30,000 of counts, his TC has come down to 29,300. LFT, there is a bit of improvement in the OTPT levels. And on 11th, still the patient was febrile with FiO2 on ACBC mode with FiO2 of 50%. And actually, PEEP was, it's not 3 months. PEEP was like 10 at that point of time. And the PF ratio was 150, and plateau pressure is 25. As patient is not improving by even on day 4 with by the day 4 also, he was his antibiotics were changed to polymyxin and 5 lakhs IVBD, and he was started on DVT prophylaxis with heparin in a subacute BD.
Madam, already day 4. Did you got any ET section? Any?
Sir, actually, patient got admitted 8th into the ICU.
No, now you are telling 4th day 4. Now you're talking
Seventh he came, seventh
No, no.
midnight he
already,
came.
I know, I know. Already you're telling day 4, day 5. What is any cultures reports, any
No, they were
grams,
not.
anything?
Cultures were done on 10th, sir.
No, no,
Because the
suppose it would be done on the day. Immediately when you intubated, you send the already cultures.
It was done on 10th, sir.
Not sent, immediately after intubation. But then gram stain, at least gram stain, anything got it? Why you are
No.
exciting like that, going on antibiotic without any
Cultures
evidence?
were sent on 10th of that 10th of July only, sir. On
Intubation
the
on what
Monday.
date? Intubation on what date?
Intubation on 9th he was on
Gram
9th.
stain? Immediately when
he was
intubated.
9th he was intubated, sir.
Yeah, what is the gram stain? Any organism?
Gram report was not available in this, sir.
No, your protocol tell me. It may be this patient is okay. What is your protocol?
Usually
What you do?
we do send cultures on day 1 itself, sir.
Yeah, immediately you'll get within a few hours, you'll get the gram stain. The
Yeah.
organisms are there or not?
But there is no gram stain in the lab report, sir.
No. What you do is tell me. This is not the case. Is not we are discussing. Not the case is only for a thing. But you should do what you do. You should tell how I do it. This is what is there for the future. Not for this. What is they done it. You are not totally. What you will do when this patient comes. That is our aim. Is you should tell what I do it when this case is given to me in your exams.
Yes, sir.
Not whatever they do it, forget about it. What they done the case. You should say what I do. Maybe they are not done. I will do like that. I will do like that. I will do like that. That is our motto is that to improve your knowledge. I will do like this. I will do like that. That they're not done or okay. Forget. They're not done. I will do like this. That is our aim. That you should develop your.
On the day 1 itself, I would
You
like
tell
to
whatever I do. They done this. This is the slide you're telling. Sir, I want to do this test also. This investigation or this treatment. Substantiate you. That is only our aim to you should develop. What I do it. Okay, thank you. Go ahead.
On 10th, cultures were sent, sir. And on 11th, antibiotics were escalated to polymyxin as he is not responding. And
But you are showing,
Ma'am?
Soumya, but you are showing your FiO2 on 12th was 50%,
50%.
and PEEP has gone down, PF.
No, peak was 10 only, ma'am.
Plateau pressure gone down to 25 from above 42.
But because of his febrile state, I think it's been changed itself, madam. And the
Okay.
counts are also 29,000,
Okay.
not coming down. So that's why they changed the
Okay.
antibiotic now.
Do you think
They
in
didn't stop
severe cap?
meropenem. They from Piptas, they started on stopped Piptas and started on meropenem and added polymyxin on that with meropenem.
Okay. Do you think in severe cap, is there any role of steroids? Any guidelines? Okay, if you don't know, continue to the next one. But look for that and put it in the group.
Oh, yeah. And on 12th, his FiO2 was 90%, PEEP of 9, with plateau pressure is 20-25, and driving pressure is 16.
How come when FiO2 gone up to 90 and you have decreased the PEEP? The previous one, FiO2 50 and you said PEEP 10, not 3. That's a mistake. And
PEEP was
now you
not
have
3,
gone
ma'am. It
to
is 10 only, ma'am, actually. I mistakenly typed that 3. No,
that's fine. That's fine. That's fine. On next day, patient gone worse and you have increased FiO2 to 90. Then
Yeah.
why did you reduce the PEEP? Is there any reason? There could be some reason why you have done that.
Otherwise, you tell what you will do, madam, what I do. Okay, this is a whatever they done it, you tell what you do with this FiO2 and with the people, what is your ratio?
Should you have done or I shouldn't have done? I should have done this. Say something. Yeah.
Actually, I would like to keep the plateau pressure below 30. Below 30. So,
Okay. That's below 30. Are you still on neuromuscular blockers?
yeah, he's on neuromuscular block. It is continuing now.
For how many days do you give?
They gave for 48 hours now.
I'm asking you, how long would you like to give if it's your case when you're treating the patient?
Yeah. 48 hours, I don't know very clearly, ma'am. But
Okay. Look at the guidelines and put it in the group. And what's your driving pressure?
driving pressure is here 16 now.
Now, what is it and what is the significance? How do you calculate and what is it and what's the significance of driving pressure?
No.
Okay, fine. Read about driving pressure.
I read, madam, driving pressure, but I'm not remembering now.
Is it not P flat minus PEEP is
Yeah,
driving
P-flat,
pressure?
yes, ma'am. P flat minus PEEP is the driving pressure.
What should it be? What should it be?
Driving pressure is
15, below 15, right?
Yeah. Yes, ma'am.
So there's a graph about PEEP and P plateau. P flat goes up, PEEP goes up. Still, if you have driving pressure below 15, you
Yeah,
have a probably good outcome, benefit. Yeah.
yeah, ma'am.
When we put something on notes, like we need to know about it, you definitely get asked. So you mentioned about driving pressure, you should know about what is it and what's useful. Yeah, by knowing that. Okay, you still have hypotension worsen, right?
Yeah, ma'am. He was on NORAD of 20 ml per hour and vasopressin 2.4. And his ultrasound chest shows dynamic air bronchogram with bilateral mild pleural effusion, which may be pneumonia. And on 13th, still he was febrile, and his FiO2 has been increased from 90 to 100%, and PEEP was maintained at 10, and his SpO2 was coming down, it's 84, and counts are still high. Chest X-ray, there is no evidence of any improvement, and his ET and blood did grow Klebsiella manner. It is only sensitive to phosphomycin, intermediate sensitive to colistin and amic acid. So we continued the polymyxin, stopped meropenem and started him on phosphomycin 4 gram IV TID. Stopped meropenem and targocid. And patient was started on Bactrim DS also. And that day, same day on the afternoon, he was being proned. He had a second proning.
You have, Soumya, you have 2 high dose vasopressors. So what's your blood pressure there?
I didn't mention here.
So maybe still low. I asked one question before. In severe CAP, is there a role of steroid? And here patient is on dual vasopressors, still in shock.
Here there
Is there a
role
role of
vasopressor.
giving?
Yeah, there's a role of steroid is here, madam. 50 mg 8 hourly. Because he'll have
What's the
hypoxemia,
loading dose and
which
what's
is
the per
plated.
day dose?
100 mg start and 50 mg TID.
200 mg in a day in divided doses or infusion.
Oh.
So 50 mg 6 hourly. Okay, continue.
And on 14th, 13th he was started like this, and on 14th, 14th and 15th, he was febrile. With his LFT and RFT were improving by that time. And inotropic support has come down. And he was, but his ventilatory support FiO2 is still the same, 100% with PEEP of 10. And the plateau pressures from 25, they started increasing to 36. And driving pressures also increased to 26. And PVF ratio was 65. And his counts have come down to 19,300. He was supined at 11:30 a.m. And again at 4:30, he was prone for the third time with FiO2 kept at FiO2 of 100, PEEP of 8. P plateau has come down to 28 after proning, and peak pressures were 41.
Okay,
And
when
his
we put
SpO2 is 88 to 89.
when we put somebody in prone, Soumya,
Yes, ma'am.
when we put somebody in prone, how long do we have to do?
18 hours, 16 to 18 hours each time.
Okay. Then you do supine, right? So
Yes, ma'am.
when can we put the patient in prone again? What do we have to check?
Like we have to check for like 3 to 4 hours. Then again, we can, depending on the P/F ratio and worsening SpO2 P plateau pressures are more, then we can reprone him again.
So in ABG, you check only PF ratio, is it?
PF ratio was
Okay, saturation worsening.
65 and saturation is worsening. SpO2 is 88 to 89%.
Okay. Do you not check PCO2 also?
I'll just go to the problem.
That's okay. Carry on. Continue.
On 15th,
Yeah. Tell me.
15th ABG was 15th ABG. PCO2 was 67 now.
Okay.
And PO2 was 58. pH is 7.3. And BICAP was 37. His SpO2 is 100 and the P/F ratio is like 58 now.
Yeah. Did you do any ABG in prone? Is this in supine or prone?
Yeah, that wasn't mentioned here, but I should mention. I should see what is after proning and how he is after supine. It wasn't mentioned on this ABG slide.
Okay.
Only mode is mentioned and peak is mentioned.
Yeah, when we do proning, we need to mention in prone or supine. So then only you compare whether there's any improvement or deterioration to
Yeah.
prone again.
Mm.
Okay, continue, please.
And at the he was supined on 15th. And he again reproned on the same day after 2 hours for the 4th time, as he was not maintaining the saturations and the plateau pressures are also increasing. On 13th, again.
No, sorry, you have already done this. You have done the next slide also. You're going back.
Yes.
Yeah. Yeah.
On 16th, he was on the 4th prone, is going on. At that time, his FiO2 was 100%. PP is maintained at 10. And tidal volume has been decreased to 280 from 300. And ABG was showing 7.3 of pH with PCO2 of 71 and SPO2 of 59. And lactates are 1.4 and bicarb is 43. The same day they supined him at 5 o'clock again. And again he was being reproned at 7:30 p.m. in the night for the 5th time because FiO2 has come down to 70%. Not FiO2, madam, it is SPO2. I'm sorry. SPO2 has come down to 70%, so they reproned him again at night 7:30. And his GCS were, he was off, sedation also. On 17th, his GCS was E1, VT and M1. FiO2, he is on 100% with a peak of 6, tidal volume of 20, and P peaks were 40 and SPO2 was fluctuating.
Sorry, did you say tidal volume 20?
Tidal volume 280, they did. It was decreased tidal volume, madam, because P peaks were 40 and plateau pressure was not mentioned in this, madam. And his ABG is also 7.2 with carbon dioxide, PaCO2 has been increased to 109 with SPO2 and PO2 at 74 with bicarb of 51. And his chest X-ray shows reticulonodular pattern bilaterally. That's the last X-ray I'll be showing. And again, his count started increasing. And at night, 9 o'clock, 9:30, he was supined again after the 5th proning.
At any point of time, was ECMO considered for this patient in last 2-3 days?
Actually, they are BSKY, madam. So
Okay.
it wasn't considered actually.
But when should you think about ECMO if it's not that and you're managing a case?
The P/F ratio less than 150. It's one of the this and P plats are more than 30. These two are the indications for ECMO.
And in spite of all the standard
P plats,
lung
carbon
protective
dioxide
strategy.
and P/F ratio more less than 150, then we can consider it.
Okay, proceed.
And his issues were refractory hypoxemia. By this time, his oxygen sats were come down to 53% like that man on 18. And he was having hypotension. And again, he was having fever spikes. And pupils are fixed and dilated. And on that day, chest X-ray was repeated. It was showing again a new onset of patch on the right side of the lung, suspected ventilator-associated pneumonia. And ultrasound has been done. It shows air bronchogram with pleural effusion on right side. And his ABG was 7.09 with pH, PCO2 of 150, and SpO2 76%, and it has come down to 53. And on early hours of 19, this patient expired.
So how did we manage the patient? Inpatient came with possibly cap.
Yes, ma'am. And that's drug resistant, multi-drug resistant Klebsiella.
Kuchel Babu sir, Mohan Rao garu, Varalakshmi.
Yes,
Sir,
madam.
any comments before we finish?
Yes, madam. This is actually the BSKV case, madam. So we have some restrictions in doing the investigations and other things. And one more thing is young patient came in very rapidly deteriorated. We don't know, we had to check his immunological status also. With the severe cap, we tried our level best with available resources. That's all. Anything, sir? Comments from others?
Only my request is, don't give too much of time to the student. Just give a few seconds, and if they could not able to answer, if you want to the audience to be given an answer, you should give it. Otherwise, go to the next question. Otherwise, 2 hours time is taking a lot of time. Then we should increase or put in a questions. They can write down what are the questions, and they can search afterwards. Or somebody can, they can put the answers in the chat box also. Not only moderator, anybody can put the answers. It will benefit to the students. I request all the expertise, all the consultants, please give a suggestion. Suggestion means answers, questions and answers also put it. That will benefit to the students.
Mohan Rao garu.
Any comments?
Thank you, sir. Kuchel Babu sir, thank you. And
Okay, thank you.
Mohan Rao
Thank you.
garu,
Yes,
questions
ma'am.
ఏమైనా ఉంటే what the candidate should know అనే questions group లో పెట్టండి and they get the answers and put the answers in the group. So they have
Sure.
to and also some latest studies, trials which they are supposed to know, like ProSeva study, Eolia study, all these trials they are supposed to know, because we are still in the basic level of discussion. We didn't go up to that, but what they're expected to know, alanti konni suggestions, put them in the group. Thank you.
Next time we can directly we can take a one ARDS case, madam. Instead of cap and ARDS, it is taking a long time, kada. Huh? What?
Mohan,
Kuchal
we
Vasu, sir?
need to have one more ARDS case to discuss.
Whatever it may be, I think we'll give what I do. I think better instead of giving the So Mohan Maharaj, what do you think? Instead of presenting their case, what your normal exam, how will you give a case presentation should be given from our side only. What then they will, how will do they? I think better they should say. Instead of
And
doing
a
already
hypothetical case iddama, sir, with
case
investigations
system,
and details.
then they can ask what is the different diagnosis, how to investigate, how to go ahead with the treatment. Instead of already done case, I think their time is wasting. Whatever they're done, it's telling. Sometimes it may be due to what the Mohan telling, some resources are not there, they cannot get the something. Instead of that, how they do it, they should say. How the exams they will present like that. I think you can give the cases. I think any bank is there, Mohan Maharaj. I don't know about the exams. You are going for examiners. Did you get those any bank?
అంటే సార్ అయితే సార్ అంటే actually that is actually confidential, sir. But we can get so many books are there, sir.
How it is there, you know it. You can prepare.
Yeah, we know, sir. We know, and also so many books they came, sir. We can choose and we can give as a as you said like a OC case, a model question.
A model case, and they can what is the investigations like? They will give the investigations also.
Yes, sir. Yes. They will give, sir. They will give, sir.
They
Then
give,
better,
sir, they give history
you are doing
investigations.
You might be knowing how to that is a better. Then Varalakshmi can she's not at all talking. I thought she will be more resources person. Where is the Varalakshmi madam? Are you there? I think will Mohan Raj will give assignment to her. She should make a good case presentations. Then she search from the some literature. I think where is available. We'll give the cases and they should prepare it. What Mohan Raj? I think better that will be. Instead of wasting a lot of time.
Yeah, for ID system like that only. Yeah.
And then why don't we have already telling the some cases are there. You can give before also 1 week before they can prepare on that basis. Time waste will be come down. That a lot of 2 hours still so many things are not at all discussions are not. Think you can think over. Think over and ultimately benefited to the student. That is our aim is they should benefit it when they go to the exam. They can face how to presentation, how to they should know. That is our motto is like that. Okay.
Yes, sir, we'll do like that. That's why I skipped a few slides and we asked how
not
you
necessary.
do.
Those are not necessary. Actually, exams ఎలా ఉంటుంది మీరు అలా question ఆ పేపర్ తయారు చేసిస్తే బెటర్ అమ్మా. That will be more useful for them and for can go on questions also easily can go time waste ఉండదు. The same question pattern also will be there. They'll benefit it.
Yeah. Thank you, sir.
Okay, thank you.
Thank you, Mohan Garu, and thank you, Soumya. And thank you all.
Thank you, sir. Thank you each and everyone. So now we'll close the session.